इस बहुत ही इम्पोर्टेंट टॉपिक के लिए। मिस्टर डिखिल सी।
Thank you so much, Sister Neema. That was so kind words for me, though I don't know whether I deserve this much kind words. Good afternoon, everyone. Thank you for joining us. We are trying to explain you the how to fill ICU charts. I am representing the Sister Vidya and my team, who comprises of Brother Sunil, Sister Rochita, Sneha, and Brother Sanjay. So let's move ahead, and I want to congratulate Sister, our CNO Madam, Luzsamma Ma'am, and Dr. Sujith Sir and Anil Sir for taking this initiative to take all of us so skillful. So without wasting time, let's move on how to fill the ICU charts. So here in this small talk, we will be discussing about how you can fill the ventilator parameters into the chart, blood sugar, and drug infusion. And I will be explaining how you can take ECG and how you can use the ICU monitor. These are the 5 things we are going to cover in this small talk. So let's begin with the ventilator modes. As you all know, we have different ventilator modes based on the necessity of the patient. And you can see in the slide, there are 4 modes which is explained. One is NIV, SIMV, VCV, PCV. The difference between all the 4 is in NIV, the oxygen will be, or the air will be given externally through the mask. And in all other 3, the oxygen and the air will be given through the enterotracheal tube. So how you can identify this and make this into ICU chart? This is the question. In the ventilator monitor, you can see here, you can see the mode. I think everybody can see that the cursor is moving. It is written NIV. So you can write that. And here it is respiratory rate and tidal volume in this area. And here it is FiO2, and here it is PEEP and pressure support. If you able to pick these, half of your work is done. You can report, you can enter it very easily. Now where you have to enter, this will be the like chart you will be getting. So here we have written a like a demo patient's parameters. BP you can write 120, 80, respiratory 25, saturation you have SpO2 here 94, ventilation mode here. This is the most important thing. If it is NIV, we will write NIV here. If it is other modes, we will write that mode here. FiO2, we can write it here. PEEP and pressure support, you can write here. And tidal volume, you will be writing here. And set out rate, you will be writing here. So this is same for SIMV pressure support also. This is the next mode I'm showing you. So this you can see here, and respiratory tidal volume here, FiO2 here. And the PCV mode here, pressure mode support, pressure support here, and PEEP here. Now, the same thing, same parameter, no difference. The same thing, respiratory rate, saturation here, ventilation mode here, FiO2, PEEP pressure, tidal volume, and set rate. And now coming to the volume controlled ventilation setting. You can see respiratory rate and tidal volume. It is here, and FiO2. And VT, it will be written here, and pressure support, it is not here because it won't be coming here, and PEEP, it will be displayed over here. And this is pressure control ventilation setting. Here it will be PCV, respiratory rate, tidal volume, FiO2, PEEP, and pressure control data will be available in this part of the ventilatory mode. Now, how you can write the volume control and pressure control setting. These, as you all know, this much all you understood now. FiO2 is also more or less same. In volume control, see, there is no difference of pressure here. So you have to write it down accordingly. And here it is fixed. It is giving, we are giving the 25 pressure. So we have to write accordingly. And tidal volume here, you can write the set dot here. This is how you chart about the ventilatory settings. I hope everybody will be able to do this very easily from now onwards. Now coming to the blood sugar charting, we all do, even if you are posted in OPD, even if you are posted in ward, we all do the blood sugar charting. Now how you can enter that in an ICU chart, that is our next thing. We have two kinds of administration of insulin. One is insulin infusion and another one is subcutaneous insulin administration. And commonly insulin regular is used as insulin infusion. In subcutaneous, we use regular insulin or we use mixed. Now, see this chart, you can see here it is written how much the dose of insulin. If it is NPH also you have written, and insulin regular also it is being written here. And commonly in ICU there may be 4 types of like RBS we may need to do: fasting, before breakfast, before lunch, before dinner. This is very common, and it depends on the patient's condition. And insulin infusion charting, how you can do this, you can see this here. Insulin injection, it is written 1:1. I hope everybody it is clear. And here the rate is written 4.5 ml, this rate, whatever that may be the order of doctor. And how you can prepare 1:1, you take 20 ml in 20 unit of insulin. So this we will be doing as per the doctor. Now, when to inform doctor? This is very important. How you can do that? If the RBS is less than 100 or more than 200, you straight away go and inform the doctor. If it is less than 100, please stop the insulin and go ahead. Otherwise, the patient will go for hypoglycemia. If the fasting PP is less than 126 and postprandial after food, if it is more than 200 also, you have to inform doctor. So that is about the insulin. We have covered the ventilation and insulin right now. And now we will be moving ahead with the drug infusion charting. This is very important parameter in the ICU. Commonly, we go for sedation and inotropes and other few important life-saving drugs. And let's see about the sedation. Common use drugs are midazolam, fentanyl, and dexamethasone. And the infusion rates are commonly 1 to 3 ml, 1 to 5 ml, 3 to 5 ml, respectively. Now, how you can enter here is, here you can write the name of the infusion, what you are doing, and ml per hour can be written here. This area, the time is already printed over there. This way you can write it down. And coming to inotropes, we have 3 commonly used inotropes: noradrenaline, adrenaline, and vasopressin. Adrenaline comes with 1 mg per ml, that is 2 ml is equal to 2 mg in the ampule. And in adrenaline, 1 mg per ml, that each ampule contains 1 ml is equal to 1 mg. And vasopressin, 20 ml each well contains 1 ml is equal to 20 unit. Now let's see how it is being prepared. And noradrenaline and adrenaline drugs mg to be added in 50 ml of saline is equal to 0.03 into body weight. For the single strength, I am saying, you can see in downside for 60 kg adult patient. For 60 kg adult patient, we have calculated that 0.3 into 60 is equal to 1.8 mg in 50 ml of NS. So I have already told you, see, you can see that 1 ml is equal to 2 mg here. So it's more or less 1.8 mg here. So what you can do is you take 1 ampule and dissolve in 48 ml of NS and move ahead. And vasopressin, it is 1 ampule is equal to 20 unit. So that you can add in 20 ml of saline, that will come 1 ml is equal to 1 unit. And common rate will be 1.2 ml per hour to 2.4 ml. It varies actually. And that how it varies, we will see in the next slide. So you can write it here also similarly. And the point what you need to take note here is, when you have an inotrope going on, first try to write the inotropes and then the coming drugs. You make sure that this, because inotropes are very life-saving drugs. And let's move ahead. So guidelines for inotropes: administer as continuous IV infusion via an infusion pump. Try not to give through peripheral line unless and until it is very emergent. Label the drug concentration, as sister already explained. Central line administration is preferred. Transiently can be given through peripheral line, only transiently. Do not administer sodium bicarbonate or any kind of alkaline solution through that IV line. Avoid abrupt withdrawal. you have to taper it down very slowly. Other commonly used drugs are KCl and soda bicarbonate. You know the importance of it. Do not push it directly. The patient will die. Do not give it directly. Now let's move on to the next topic, that is ECG and ICU monitor. How you can take the ECG. This is also a very important thing. Almost everybody knows, but still I'm just rewinding it. You must understand what are the parts of the ECG. You can see the ECG machine and leads, power cords, chest leads, peripheral leads, and the power cord also you can see in the picture. These are the parts which will be available for you. So here you can see the chest lead placement. How you can place the chest lead is fourth intercostal space left side, you can space the first, and second and third you can place on the just opposite side, just in this pattern, and fourth you have to put it in the mid clavicular line, and fifth and sixth, fifth in the anterior axillary line and sixth in the mid axillary line. If you know this, half of the ECG is right. And now coming to the placement of the peripheral leads, how you can place it. You will be having that written in the peripheral lead itself, and if it is missing, you can find out from this color: right arm white, left arm black, right leg green, and left leg red. So with this, you can go for ECG limb placement, and you can take the ECG accordingly. Now coming to the last part of the topic, how you can do, how can you identify from ICU monitor, and you can record it accordingly. You can see in this monitor, this is mid-ray monitor, and here we have ECG leads. We have given 2 leads here, and now we have saturation SpO2 written here, and this is arterial BP, and here it is mean arterial pressure. You have CVP here, you have respiratory rate, you have NIBP here, and here temperature if it is being connected. And these are the things what you can get from this monitor. Now you can write, you can see this ECG here. This is first lead and fifth lead. We commonly use second lead. And here we have monitors very sophisticated. Even we can have 12 lead also, but there is no need for. Even if you find any variation, please inform doctors so that they will come and assess and do the management accordingly. You can see the respiratory rate also here. You can see the saturation SpO2. There is a common mistake that sometimes the probe will be displaced and saturation will be showing like different things. So always look for these waveform also, so that make sure that you are not giving a false information to doctor. NIBP you can see here, and arterial BP, as I told you, this is the way how the waveform of the arterial BP will be coming. Already Suresh sir has explained how you can monitor that. And the same one, as I already explained, BP you can write in this start place, respiratory rate here, saturation here. So with this, I think we are coming to an end. And I again congratulate all the nursing staff, everybody who are working so hard to make all of us safe, to give the better patient care. And this is a real achievement. SGPGI is doing very well across UP and across all India. And it's all because of our teamwork. And again, Sujith sir, I really want to thank you for all the support and all the microscopic monitoring you have done towards all of our presentation. Thank you very much. Thank you all.
Thank you, Mr. Dhikhil. आज जैसे Dhikhil का टॉपिक था how